this one either releases neurotransmitter or it doesn't. If it does, it's going to inhibit this one. If it doesn't, it's not going to inhibit this one. Okay? So that's why I said this one inhibits the inhibitor. So if that one doesn't work, this one does, and our muscle contracts. If this one is working, then this one is working, and this one isn't. You just have to think about, is it going on or off? And again, we're going to get to this level in our next unit, which is kind of gradually introducing some of these concepts. But back to basal nuclei, I just want you to understand the basal nuclei are involved in both of these. If we have too much, if we don't have enough of this, we don't have motor function. If we have too much of this, we have too much motor function. So, let me rephrase, I think I phrased it wrong. If we have not enough of this, if we have not enough of this, or too much of this, we don't have motor function. If we have too much of this, or not enough of this, then we have the other, the opposite side. Okay? And this can be affected, so subthalamic nucleus is excessive, a lot of a type, I'll show it to you, it's called hemimelismus. It's got a lot of movements like this, a lot of kind of, I'll show you a video of it, one-sided. They do this a lot, swing their legs around, kind of a rotational kind of movement. Okay? If the globus pallidus is affected, Huntington's chorea can be involved. That's a genetic disorder. Those are all too much movement. So the last couple of slides I want to show, these are just really basic about how these structures work. And really, and I think I did a great job of it, give me a hand, I just wanted to show you how complex it is.
Very good job of that.
Now, let's make it more complex.
No.
I do. You'll get over it by Tuesday. All right. So most of you that have heard of Parkinson's disease have also heard of dopamine, right? So someone, at least in the early stages of Parkinson's, the key aspect of that is not enough dopamine. And dopamine is made by cells in the brainstem called the substantia nigra, which means black substance. Dopamine is converted from amino acid known as tyrosine. Remember when we talked about skin? The melanocytes took tyrosine and converted it to melanin, which is a dark pigment. So these cells are taking tyrosine and converting it to dopamine, and there is a dark pigment that occurs as a result of that as well, kind of a side effect. And so in the brainstem, we can see this area of dark matter, and that's what substantia nigra means. So dopamine travels to the caudate putamen nucleus, and it activates our activator and inhibits our inhibitor. Simple as that. For those of you doing Parkinson's disease. Okay? So remember, increases motor activity. All right? Back to what we knew. Increases motor activity is this pathway. Decreases motor activity was this pathway. So dopamine activates that first one. So it's going to increase motor activity, and it's going to inhibit the pathway that inhibits it. Exactly. So dopamine makes it more likely. It excites the direct, which is that first one, inhibits the indirect, so its effect is to increase, make it easier to do motor movement. That's what you need to know about it. Okay? So if you don't have enough dopamine, this is where it gets a little, okay, well, let's see, how does this work? We know the result is if you don't have enough dopamine, that you have this masked faces. People don't have expression in their face. Their movements are almost gear-like. kind of, like they're going through cogwheel motion is kind of often how it's described. And they have a real kind of a shuffling gait. They have a really hard time flexing and extending their joints. So again, it's not that the muscles aren't working. It's not that this pathway to the muscles aren't working. Again, it's like you're sitting in the car, you have the will to do it, you know, you have the desire to do it. The engine will turn over, you just can't turn the ignition switch to start the engine. So we can't get all this going to start this. Kind of seems to be the best analogy that I came up with today to illustrate that. Something a little less easy to explain, I can't explain it since the scientists who have been studying this can't explain it, but there appears to also be a component of Parkinson's that has to do with, and this is where the weird word is, the decision to do a movement. And I'm talking by decision or will or choice or selection. It sounds like it's all frontal. So you've heard, you may know somebody that has depression and they want to be active. They don't want to lie in bed all day, but it seems like they can't get over the hump to do that. So that, on an unconscious level, seems to be an effect of Parkinson's lack of dopamine. I can't explain it more than that. But we do know that someone who has Parkinson's, that is in this kind of immobile state, faced with an emergency, can move quickly and easily to take care of the emergency, and then they're back into that immobile state. So something about that emergency allowed them to override and able to turn on that ignition, able to make the choice. And it's not, I don't want you to find a Parkinson's and say, you just don't want to move. You're just sitting there being lazy. So it's not that, all right? But there's a disconnect. It's an unconscious kind of will. And I can't explain it any better than that. But it's more than just this semi-type of paralysis. Okay? So there is, and this is, I just put this up there because my morning students that are doing Parkinson's disease had asked about acetylcholine. I'm not even going to go there, so we'll just skip that slide. It has an effect. I just don't want to confuse the issue. Unless you guys want to talk about acetylcholine, you can get that off of the, it's off the D2L, but I didn't. All right, so the activity of the basal nuclei is initiated by information received from the sensory cortex, that would be this neuron right here, okay, from the thalamus and from the brainstem. It's channeled through the globus pallidus and then goes back to the motor cortex. So it assists. It's not the actual one that goes to the muscles, but it modulates that. So now why do we need it? Again, we would have too much movement if we just responded to any stimuli. This just provides kind of a template for controlling and deciding what can turn on the motor system and what can't. So if we destroy the motor cortex itself, that's mean if we destroy the precentral gyrus, okay, not all of it, but parts of it can keep you from doing fine, discrete, playing the piano, all right, sewing, writing, that type of thing. But you can do large movements. You can move your whole hand. You may not move, be able to count 1, 2, 3, 4, 5, but I can do this, all right, more gross, crude movements. So if we don't have any corpus striatum at all, we wouldn't have any movement. Okay? So preparation of movement, positioning the body to make those movements. So there's just a lot of, and these are general statements, these are not specific statements that I would test you on. It just kind of starts to help you understand a little bit of how this is involved. And it's because scientists themselves, medical doctors, don't understand everything and how this works. We do know that for some tremors, all right, Parkinson's or other types of tremors, medical surgeons can go in with a laser and GPS even and pinpoint by sending a signal and seeing what part of the body moves. There was I think it was a cellist in the orchestra in Atlanta a while back when this was first starting, deep brain surgeries, and had a tremor and had a difficult time playing a string instrument if your hand is constantly doing vibrato. It doesn't work with every piece. And so they were able to pinpoint that area of the globus pallidus that was not working properly and destroy it with a lesion and stop the tremor for at least 3 or 4 years. Okay? So when we look, this is a diagram from Netter's, and there's actually too many lines on here, but if you have Netter's, and we have a book here, I'm not doing this for the thalamus, but this is the head of the caudate nucleus right here, okay, bulging into the lateral ventricle and then curving around with the lateral ventricle itself. So right here is the head of the caudate. This would be the thalamus right here. See how it gets larger in the back? And third ventricle is this slit right here. So this kind of helps you from the top looking down, again, get a different view of these structures. This is a transverse section through that same thing. So rather than seeing the shape, we're seeing the gray matter. So this would be third ventricle. So this is thalamus. Here is the head of the caudate curving around, and we're seeing the tail here as we begin the inferior horn. And then here would be putamen and globus pallidus, third ventricle, so that makes that thalamus. So we're going to keep looking at these views, and as we talk about more of these brain structures, you're going to start going, yeah, I remember that, that makes sense. And there'll be less and less of, where are we? So corpus callosum here and here. Okay. And then that same similar view of what we're seeing here with the thalamus, corpus callosum. So just those slides of the diagrams and all the cross sections are new, but I have this up there on D2L. It's the second basal nuclei. It says under detail, it says PowerPoint, and it says lecture 5 again, basal nuclei, and it's that second one. I didn't delete the other one yet. I've already done this, so we're not going to talk about it. So there can be lesions of the basal nuclei, all right, when we don't understand what's going on. So the choreiform are dance-like movements. This is Huntington's chorea. Huntington's chorea is a genetic disorder. Typically affects the globus pallidus, but it can affect the subthalamic nucleus as well. You don't have to know that. I want you to know that these types of movement problems, dyskinesia, is effect of the basal nuclei. Okay, so if I were to say someone with Huntington's chorea is due to damage of the precentral gyrus, or damage to the hypothalamus, or damage to the basal nuclei, you would pick basal nuclei. Okay, I wouldn't pick just one of those components. So let me show you a video of a gentleman with hemipalismus.
On one side, and are usually contorting and continuous, and of a rotatory nature. Hemipalismus also merges with hemichorea. The abnormal involuntary
meaning on the
movements of
same side, one
hemipalismus
side of the body.
usually come about as a result of a CVA. The lesion usually involves the subthalamic nucleus or corpus luisi, but can also involve the globus pallidus or the connections between the globus pallidus and the subthalamic nucleus. Here we have a patient with relatively continuous, severe contorting movements of his right side, involving the arm not quite as much as they do the leg. We see the continuing rotatory movements of his right leg.
This would stop when he was asleep.
Poor guy, he walks down and kind of like jumps on one.
Yeah, subthalamic nucleus would be that. But again, I'm not going to be that specific, just recognize the basal nuclei. Yeah.
When he walks, does the same thing happen? So does he like kind of jump on one and then like
Yeah.
walk on the other?
I looked for, when I was in nursing school, we saw a video of a woman that was, she would try to sit on her hand to stop it from moving around, and it just gradually kind of work its way out. And it's like, what, you can't do anything. You can't hold a book to read. You can't accomplish any task if it's just doing it on its own. Okay? You can, no, you can tell him to put his foot behind his other leg, but
Can he take any
eventually,
medication for it
Yeah.
or anything like that? I mean, to stop it or?
not to stop it, there could be some to suppress it, but then you're running the risk of not, just flaccid and not doing anything.
Some
So,
nice little trank.
kind of in between for both of those.
Put it down.
I love C. Pink's my favorite.
Medias during the Middle Ages, and later to describe the abnormal gait and stance of patients with Sydenham's chorea. We now use the term chorea, however, to define a class of abnormal involuntary movements. Choreic or choreatic movements consist of individual, brief, purposeless, non-repetitive jerks of individual muscles. These tend to be rhythmic and non-patterned, but they appear in series or groups, which result in rather complex movements. The movements are made more complex by the patient's attempts to mask them by purposeful movements. Here we have a patient with fairly severe choreatic movements involving various parts of her entire body. Here we see movements involving the jaw, the tongue, the mouth, the neck. Each is an individual, brief, sudden, purposeless jerk.
It's her job.
In this individual, the choreatic movements are due to Huntington's chorea. The individual movements, however, look the same no matter what the etiology of the choreatic disease.
Some of this is seen in Tourette's, where they'll have, sometimes Tourette's is just involuntary noises or speech. Sometimes it's foul language, or it can be a sudden movement of their head, and that's thought to also involve some of these areas. I had a student a few years ago whose grandfather had died of Huntington's chorea about 4 years prior to that. Her two uncles had it, and she was just starting to notice symptoms in her mother. And her mother was in denial and was saying, no, that's something else and that type of thing. It usually shows up in someone's 40s. And so by then you've already had kids if you're going to have kids. And they had gone to the conferences on Huntington's chorea in San Diego. They had gone to once or twice a year. So she knew what she was up against. There is a genetic test that you can take to see if you have Huntington's chorea, because it is fatal. She was I know it would be a big relief to know whether or not I had it, but I think she kind of assumed she did, and she just didn't, she still wanted to have the hope that she didn't, rather than have it confirmed, and then for the next, she was about 20, 21, and know, for the next 20 years. And she said, it's a problem dating, because I don't know, do I tell a guy right away? Do I wait till I think we're serious? Do I assume that we're serious and tell him and then we're not? And it was just, and people have this choice with a lot of different things. Do I tell a guy I have kids, or do I tell my date, of a guy that, I've got custody of the kids, or that I have terminal cancer, or that I used to have cancer, but now we're in a relationship. So that's a common question with a lot of people. How much do I share of my medical or personal history at what time? But it just seems such a heavy burden to have to try to make that decision. And so far she had decided not to do that. There was a case in Georgia, the late 90s, early 2000s, of a mother who had 3 sons. The father had died of Huntington's chorea. The oldest son had it. And I'm trying to get I may have the numbers straight on which son, but one of them had made his mother promise that if they got it, that they wanted to be put out of their misery. Now, whether they had it so far along that they couldn't kill themselves, but she did kill one or both of her children when they had Huntington's chorea, and she was brought to trial for murder. She had been a health caregiver and retired to stay home and take care of her kids. She was acquitted for their murder, but was not allowed to ever take care of anybody, nor her own. She had one surviving child that also subsequently developed Huntington's chorea. And I just can't imagine as a mom, you know, the guilt that you would feel having seen your husband and 2 or 3. I mean, it wasn't, you know, necessarily just she had them before she knew what was a possibility for that. But there was enough of an emotional drain and brought forth by the defense that she was acquitted but not allowed to take care of her surviving child. All right, so let us take a break there. And when we come back, we will start with the diencephalon. So make it at 15, come back at 20 after, okay? I'm not sure how it's staged. We started very young with it.
Yeah,
It usually shows up in the 50s. It shows up earlier with football players and
Shut up.
fighters, boxers, because it seems to be increased fighters.
I'm gonna go to the bathroom first.
Get Parkinson's with
Extremely hypocritical.
drug abuse.
Thank you for letting me come up with
Will
Bobby.
hold my hand?
No, thank you.
Commonality is thought to develop. Well, Parkinson's usually is in the 50s unless you have these other exacerbating factors. And in the earlier micropox, I think it was late 30s. Yeah, he has some kind of a show.
Was it really?
When? It's, like I was saying, it's usually around the 50s. 40s would be, there is early. Oh. The earliest it can be that, oh. There isn't necessarily, I don't know, it's probably something that there's not like a blood test for it. I suppose they could do dopamine levels, but it's usually symptomatic based. And then they would look for a variety of other behavioral tests that can be done. The women's coach of the Tennessee Volunteers, Shasta King, was diagnosed 2 years, well, she at least released the diagnosis, I think it was 2 years ago that she just retired, with early onset Alzheimer's. That's Alzheimer's, not Parkinson's. So yeah, hers was all early onset Alzheimer's, which is different. But usually the symptoms occur because people have difficulty performing fine function. So writing changes. It's usually self-reported. They show symptoms kind of like ALS. Yeah. I don't think that there's a blood test for it. Yeah. And there's medication that you can take early on. They've tried stem cell transplants. And now one of the treatments in these new brain stimulus, where they insert electrodes into the brain and try to overcome the lack of dopamine by directly stimulating either the caudate or the thalamus, and try to get it going. But one of our faculty, her mom has Parkinson's, quite severe. And so definitely can cause death because as these cells are no longer being stimulated, they die, and their lack of stimulus kind of causes a gradual spread of inactive neurons. And so while you wouldn't normally be fatal to die of not having your muscles able to work, it actually becomes more of a dementia type of and then that expands other neurons in your brain. It's the type now. Affects the facial muscles and mostly the big joints, so shoulders, knees, hips. Yeah. There's the tremor can be a manifestation of Parkinson's, or it can be something that might have it's embarrassing because he teaches, a class, and his one hand does this a little bit, and so he doesn't but there's nothing you can do about it. It hasn't doesn't have any of the other problems. The other muscles work perfectly fine. So just a tremor only can be just the globus pallidus, or just some small portion. Okay, so not enough. Okay, all right. So if you have, for dopamine, put dopamine in here. Not decreased dopamine, then causes decreased motor activity. Yeah. So this pathway doesn't work. Yeah. So that would be decreased dopamine. It would mean pathway 8 wouldn't work, and decreased dopamine would mean this pathway would work. And so you would have decreased function. So we don't have enough dopamine, we don't have enough motor, and we don't have enough activation, and we have too much inactivation. Okay, so the top one is activating, the bottom one is inactivating. Okay?
So, two things. First of all, it's not Parkinson's like to have the muscle generation. But the way you're describing it is, if that was the case, the motor neurons wouldn't fire.
What do you mean by gyration?
Like they have twitches, and like I remember very specifically when I was tracing one of the Erica, she had Parkinson's, she always had her whole right arm would basically do twitch in this motor.
That would be the rotator kind of movement.
Yeah, and she also had her hand was shaking, and she had a very trembly voice. And so I always thought it was because the muscle was like firing all the time, so to say.
Well, it's the muscles that are firing, the muscles that aren't firing, kind of thing. So you can have. So depending, there's all. This is just very. This is like 1,000 times more complex than
I'm getting that. That's what's bothering me. Is like I know there's something more, and I'm not getting it.
And there is, but my goodness.
So
I tried to read it last night, and I mean, part of it is you're reading. I hate the reason I hate genetics is because everything is in letters, and it's the ACA gene, and when you look at it, it makes sense for what those letters stand for. But if you don't know what those words stand for, then it's like reading a foreign word which I can't connect to anything. So, and they'll bring in other nuclei that are. So there's a nucleus accumbens that's involved in some of this, and it just goes, okay, let me read about this, and then pretty soon you're way over here, and it's like, I still don't understand what this is doing. But, so with globus pallidus, if we if we have our problem instead, is with this pathway here, or so that we're not blocking this one.
Do something else.
And
Do so much.
some part of the motor, so each of these, I just drew a picture here, but each part of this actually goes to a specific
Yeah.
area of the precentral gyrus to a specific muscle.
Okay.
Okay, so it's not just an overall activation of all the muscles. So that's why they can go to a specific part of the globus pallidus and kill it with a laser and eliminate a tremor in one particular location.
Because I know.
Because this guy that I was talking about that had his tremor removed had Parkinson's.
Because I've seen there's this video of a guy who's demonstrating this new technology. It's like I don't want to call it pacemaker, but it kind of is. It's like an electrical
Brain
current.
stimulation.
No, it's
It's
implanted right here. He can turn it off and on with like a wand.
Uh-huh.
And when he has it on, he's able to work perfectly fine. But when he turns it off, like after a while, his hand starts to tremble, and then his whole arm starts to tremble, and he
Well, it probably is a deep it would be sending electrical wires up to his brain.
Okay, that makes sense. So, but it was weird because he was able to like turn it off and on. And he said he has to turn it on when he sleeps because he can't sleep without it.
There was a physician called, it's a current show now about a guy who has schizophrenia, and he teaches like a psychobiology class. He works with a divorced couple. She's an FBI agent, and her ex-husband, they're really, really young, is a police officer or investigative officer. What's it called? It starts with a P.
What network is that?
Oh, probably one of the cables. Not. Anyway, there was a show on it about a woman who had that.
The stimulation.
Right.
Mhm.
And they had found some problems with it, and they were going to recall them or turn them off or whatever. Anyway, there was a jealous woman in this situation, and she had the code she worked for the company that made these things.
She turned it off.
She turned it off, and the person just went nuts and fell, and anyway, was involved in a murder and all this kind of stuff. But yeah.
Yeah, because I mean, I did a lot of reading about the brain on a very basic level with my mom because I just wanted to understand it. Like ALS, from my understanding, is the upper motor neurons that are getting wrecked, so to
It's
say.
peripheral.
Well, no, I thought it was the upper motor neurons because if you stimulated the neurons down here, she'd like contract her hand perfectly fine, but if you didn't.
It was so I'd have to double check.
Because from my understanding, MS is the peripheral.
The other way around. MS is central.
I thought MS was the degradation of the myelin sheath of the peripheral nerves. Is in the central nervous system. And then ALS is
Я думаю, что они тоже.
Black
Такие,
nurse.
потому что мы смотрели, такие же мы смотрели. Эти,
What I remember, and you probably know, I'm sure you know way more
смотри,
about it than I
вот это вот
do.
brain, да?
ALS
Это самое.
is
Вот она. И вот это your things.
Нет, это биометр, а там есть
I
эти,
know
которые
MS is
ходят
central.
рутс.
Ну, это
Мы
рутс,
как
это
рутс.
рутс.
All of it interesting.
Это рутс. Но это пиометр.
So,
Это рутс, в которых
yeah.
идут нервы.
the way
Какие
it sounded to me
пиометры?
is MS was just
Пиометр,
a
пиометр
signal
делает,
to get
который у тебя лигамент.
there.
Это не лигамент, Соля, это я рус тебе нарисовала.
А, нет, это мне нарисовала.
Ладно, это я тебе рус нарисовала. Ладно, хай будет рус.
Because you
Видишь,
could
это
stimulate
рус.
her nerves down here in all
Вот
the
brain.
site where she had
Окей.
her hand was stuck in this position.
Вот это, значит, получается, у нас центральная нервная
But if you
система,
stimulate
а
it,
уже
it
нервы, от
flexed
которых
down
отходят, вот это вот,
If she
вот
tried to
этот
flex the
хвост,
wind, it was very
это, наверное, уже
painful, she said.
периферическое.
And so it
То есть,
was
получается, вот эти крылья бабочки и рутс с ними, и ганглион, это часть
as well as
сама, или ганглион тоже
stimulation, like they're trying
периферия.
to get the nerves in
Я
the
не
arms
знаю, это
to
надо
send
спросить.
signals down the G's and EKGs on her head. They would.
Честно, не догнала.
It was. I wouldn't know the actual passion probably there, but this is what I that's the way they were doing it. So
Я не сказала.
it's just
Это, вот эта
I'm like,
часть,
it's
это часть
kind
спинного
of
корпуса.
like making more sense, but at the same time, it's less. I know you're simplifying it, but it goes like the rabbit hole. It's so deep, and I'm always wondering.
Plus, there's a whole bunch of other rabbit holes that sort of end up when you come out of it too. Like, entirely different part of the brain.
Exactly, so, I mean, it's just,
Yeah, I usually don't even go into it at this level, but my morning class had already. So last night, I was like, okay, I'm going to search for something that makes sense. The first place I came to was, well, in 1997, we believed this, and now it's like, no, you can't do something that starts changing things. So then when I have this site on the PowerPoint that I put up on D2L, so I put the website on there for that. But this seemed to be without all the other stuff coming in, read about, and then this new this, and the other times this can happen, I don't need any of that. I just want as black and white as possible. And so, yeah, I mean, there are other stimuli that can come in. There's other cells here. These are linked, like I said, to specific parts, regions of the three central gyres, and specific muscles that are affected. ALS usually starts with one set of limbs before it progresses to others. I don't, what I don't understand about MS is it appears to come and go at first.
yeah, I have a friend who has MS, and it comes and it goes straight, they say it's an autoimmune response?
Yeah, I saw a diagram of that showing,
so it makes sense, I mean, if you're,
it's like it remakes it and then it disappears, and it shows up somewhere else where it disappears, and then that gets remyelinated. So it's an autoimmune attack. The diagram that I saw on Sunday was an autoimmune attack on the cell body.
Нет, это раскрыли биоматор и растянули.
so
Она мне
the only,
показала где-то здесь.
Which?
Между, она
Did
получается
I tell you about the progesterone thing I was reading about? I looked that
не
up.
именно, смотри,
No.
просто вот
So
смотри,
this case of the
они
woman
именно не вот
that
здесь вот,
tried to
вот
ram
здесь вот
the
торчат, а они,
security
если
gates
посмотреть сверху,
at
то
the
они
White House and
получается
fallen down the stairs.
не вот здесь,
She was
а вот здесь.
pregnant.
Если посмотреть сверху,
She had a one-year-old child, and she'd been normal, but her family said she had postpartum depression.
oh yeah, you mentioned something.
Yeah, so I
Вот
was
эти
reading it,
вот
and
articulate ligaments, а
progesterone
вот эти вот, смотри,
can increase all of the
между ними, типа того. Зачем?
and it can increase
Что
the
зачем?
number of ventricide.
Зачем они нам нужны? Антиклотерицы, да. Они помогают держать spinal cord на месте, prevented from movement и prevented, и стабилизирует. Я это точно помню. Там это цепляется к... Ну, Оля, это как шипы. Смотри, у тебя спинной мозг, субарахноидальное пространство, и вот эти вот флексы, вот эти вот антиклот ligaments. Они как бы цепляются за это субарахноидальное пространство, и чем больше шипастей у тебя, тем больше она меньше...
Yesterday at NPR when I was driving home, I heard the story on
А эти туда цепляются уже на...
like it's
На что?
they think
Тоже на биоматоры цепляются?
Because I always, every semester, I was like, like, just the other, when we were going through the bones, I was watching the bones, and they mentioned all this stuff. And he's around me, so everything was saying, and so it's just, the way they were talking, it was, they were talking about how, I can't remember the name right now. So it's the things that cells in the brain, microglial cells that clean it out, flush it out, do all this other stuff. Because it's always the age-old question, if you evolve to sleep, sleeping is kind of a detriment because you're unconscious. And they think this cleaning mechanism is the reason why people who have insomnia tend to be sick, less functional, and while a lack of sleep can kill any organism that is getting sleep.
Wow.
I think that 10 miles
With Chris's concussion, they want you to be totally quiet. Not
Yeah, that's
listening to music.
That way you
And that,
can sit there and fix itself.
Yeah, you can actually be a little bit of
Because it's kind of like the reason you have fatty liver disease from drinking alcohol.
I'm doing it right. No,
Fatty,
it's just in the water.
build up, so that itself. There you
all right, then we interact, inhibited, motivated, so if we inhibited, we
I was
also
about to send you a
allow
picture, so you're having a moment.